Good evening. Welcome to this session sponsored by Boston Scientific, dedicated to complex left main PCI. The title is Synergy MEGATRON, Transforming Your Left Main Bifurcation Strategy for Improved Outcomes. So this is my conflict of interest. As you know, at the beginning of the 21st century, left main stenting has become an alternative surgery in selected centers. Now we have long-term outcome of these procedures, and you will see that if you look at the mortality in the syntax study, which is a very old study with old stents, the mortality in this patient at 10 years follow-up is very comparable to surgery. Now, if you look at the complexity of the coronary disease, you can see that there is no impact according to the complexity when you compare left main stenting to CABG. So the question today is not should we do left main cases, but how to do it properly in order to minimize peri-procedural events and optimize long-term outcome. So the learning objectives of this session is to review the steps for PCI in complex left main bifurcation lesions. And we'll see a nice case from Simon Walsh, who is an expert in complex procedures. We'll review the advanced knowledge on IVUS-guided PCI in left main disease. And it will be a didactic presentation from Jose Maria de la Torre Hernandez, who is an expert in IVUS, as you know. And we learn also about a purpose-built new stent platform for large vessel left main endosterial right coronary artery, which is a MEGATRON stent. So let's move to the first presentation by Simon.
Thank you very much, Thierry, for the introduction. I'm Simon Walsh. I work in the Royal Victoria Hospital in Belfast. So these are my conflicts of interest. So I'm going to present the case today of a 55-year-old gentleman who presented with recent onset angina and basically developed classical crescendo symptoms to getting chest pain multiple times per day, requiring nitrate spray, and then pain at rest. He had no infarction on admission to hospital and no comorbidities or other predefined problems. He had normal left ventricular function on a limited angiographic assessment, minimal disease in the right coronary artery, which is a large dominant vessel. And during injections into the left coronary artery, got very marked damping of pressure and widespread ischemia on ECG. So this is a limited image, and there's only one for the sake of the patient's safety. So that's the angiographic information that we have. The patient has left main and left-sided coronary disease with a second tertile syntax score, and his syntax score 2 suggested equipoise between PCI and CABG for 4-year mortality. At this point, we were in the midst of the COVID pandemic, and normal cardiac surgical services weren't in place at the time. So we have a patient basically who's got a hot acute left main lesion, who's already established on dual antiplatelet therapy, and actually who's a small business owner who's trying to get his business restarted after the pandemic and get 30 people back to work. So he's very much interested in getting a rapid recovery and back to normal as quickly as he can. So we did have a heart team discussion, and maybe at this point I could ask the other panel members what their thoughts would be regarding the case.
Simon, thank you very much for this case, which I think is very interesting to discuss. Relatively challenging case in a patient who is relatively unstable. I agree with you according to the syntax 2 that there is equipoise between CABG and PCI, and if you ask the patient, I'm sure that the patient will select PCI. So I think there is no question about that. The main question is about the strategy in this kind of case. Not only the PCI strategy, but the preparation of the patient. Will you do the case the same day or after good preparation with DAPT? So maybe you can ask Jose Maria, what do you think?
I think that this is a very nice case because it's a young patient, 55 years old, with clear angina, is even unstable. The anatomy is complex because you have left main and also other lesions. His syntactic score is 32, which is in between mid and high. But it's very important to see how we have to manage with many factors, individual level factors. This patient has several conditioning factors from the activity from his job, and also the environment of the COVID-19. It is also the external logistics, no? Then when we practice medicine, like in case like this with complex situation, we have to tackle with many different factors. And this is a very nice case because putting together the evidence, the equipoise between techniques, the preference of the patient, and the situation of the pandemic, I think the solution is really is good and is appropriate, taking all this together. But it's very nice to show how everything is combined.
Yeah, we were a little bit lucky because we were able to do a hot heart team meeting. So he didn't come off the cath lab table, and we had a discussion with surgeons and colleagues, and the patient had already been established on dual antiplatelet therapy for a few days before he'd been transferred from another hospital. So that side of things was relatively under control. Some of the surgeons might have preferred that option if in more normal times. But given the circumstances, there was a clear majority consensus that PCI was very reasonable.
Exactly.
So Simon, you decide to do the case immediately after the our team discussion, which was done in the cath lab?
Correct.
Yeah, I think it's a good option, especially when you have a patient like that with dumping when you do the cornea angiogram. Sometimes the patient may crush when he's in the awakening room. So I think it's good to continue the procedure in this kind of situation, especially if the patient is on top of DAPT. Maybe we can discuss also about the strategy. So one stent versus two stents. What is your opinion, Jose Maria?
I think for this decision, I definitely rely on the IVUS imaging. I like to do IVUS imaging of the main both runs from LED and from circ to see the ostium of the vessel of the LED and circ. And I'm going to show you later on in the slides, but I think intravascular imaging is very important for this. Sometimes angiography is very clear because you have 90% in both, and you say, okay, we have to go to a stent. In other cases, it's very clear that only one vessel is involved, but IVUS is usually required to make a proper decision regarding the two stents or one stent strategy.
I think in this case, we see this is a robust gentleman. He's quite a big guy, and his LAD is certainly not 3.5 millimeters on the limited angiogram we've got. So my immediate thought just going into the case was very likely to be a two-stent strategy. And as Jose Maria says, then you're going to inform yourself with extra information to try and make the best choice in terms of what the steps should be.
Yeah, I fully agree with you, Simon. I think in this particular case, there is many good reasons to do a two-stent approach in this case. Of course, there is many options, so we'll see what you have decided to do. But I really think that we cannot treat correctly this patient with only one stent in the LAD, left main LAD.
Thank you, Thierry, Simon. I'm going to review how's the role of IVUS guidance for the main PCI in the next slides. This is my disclosure of interest. And let's start with the ostial and mid-shaft lesions. These are not the most common, at least frequent, but still we have them. And we have IVUS, which is very helpful for plaque characterization and single stent sizing. Sometimes the ostial imaging is tricky, and you see contrast defects that are not always are calcium, like in this case is a plaque rupture or even a thrombus. Or sometimes even the ostial stenosis is because constitutive remodeling, which is very important to detect in order to prevent any PCI with the risk of vessel rupture, for example. The sizing in this case is very simple. You have to go to the most healthy left main side, just far from the ostium in the distal. And for the mid shaft, the same thing. But definitely, the distal left main disease is the most complicated and the most frequent at the same time scenario. And here, IVUS is very important to plaque characterization for decision between provisional and two stents technique, as I mentioned before, and the stent sizing. For lesion preparation, calcification is key because it's going to be the main problem in the procedures. We have to see how the calcification is in order to select the most appropriate device. For example, maybe we can need rotablation or cutting balloons. You know? In these examples, you can see calcification rings in the upper with maybe you need ablation. In other cases, you can appreciate that the calcification is in nodules, and these nodules can be really treated with angioplasty with balloon because you have room for expansion in the remaining vessel. For the bifurcation technique, provisional is a way that is more common. Don't forget that sometimes after provisional, the result in circumflex sometimes is not as good, and the compromise can be checked with pressure wire assessment. But sometimes, like in the case we have today, the 2-stent technique is not avoidable because there is a clear disease in both vessels with big vessels, like in the case that Simon presented. And then the decision between the techniques is just based on the anatomy, angulation, type of vessels, and the preference of the operators. But in this case, kissing balloon is absolutely determinant. One preference for provisional, there are angiographic factors, but we are talking about IVUS, and for IVUS, we have if we have an oxygen of the circumflex with more than 3.5 square millimeters lumen and less than 50% plaque burden, we can go with provisional because we have data suggesting that in this case, there's not going to be a compromise of circ. You see this distal main lesion with a lot of branches, not very clear from angiography the involvement of the branches, but in IVUS, we see a compromise of LED, but circumflex is free of disease or mild disease, not free, but mild plaque. Then we can go easily and safely with provisional stenting from lead main to LAD, 4 millimeters diameter and about 5 millimeters, and we get a nice result. One preference for 2-stent technique, in this case, IVUS is very helpful because when the circ shows a lumen less than 3.5 square millimeters and plaque burden over 50, then maybe you have to go to 2-stent technique. Also, when you have a failure in the provisional stenting. We have an example like this. In this case, distal lead main lesion with calcification, and with IVUS, we can appreciate that both osteon levels of LAD and circ are similarly affected by these calcifications. Both vessels are important. Then you have to go with 2-stent technique in this case to have a reasonable good result. Stent sizing, the diameter should be based on the distal landing site lumen. It's very important. But also IVUS can provide the pot sizing, which is the balloon you are going to need for the pot. And this is based on the proximal reference of the lead main site. For the length, try to select with IVUS the landing size with less plaque burden, less than 40 to 50%. And it's important also to consider the workhorse designs of the stents, because in this procedures, you are going to need sometimes significant proximal optimization. Stent sizing in the provisional is just to size according to the LAD lumen diameter. Like in this example, LAD is 3.2, 3.5. Then the stent to implant should be nominally 3.5 millimeters diameter. In the 2-stent technique, vessels are going to be stented. Then you need to take into consideration the lumen in the LAD and circ to properly size the stents to implant. Like in this example, you see a proximal LAD in the right side with 3.7, 3.9 millimeters lumen, then 4 millimeters should be the stent. And in the circ is 3.2, 2.9, then the 3 millimeters is going to be the appropriate stent for circumflex. And in this case, the 2 stents were implanted in culotte, and the result was good. I mentioned the workhorse. It's very important because lead main sometimes is very large, and LAD is not always over 4. Then sometimes you have to over the LAD a 3.5 stent to 5, 5.5, or even 6. And Synergy MEGATRON in this sense is very nice because from 3.5 to 5 millimeters is the same platform. And what is different is the balloon. Then you can go up to 6 millimeters very, very safely, very appropriately with 3.5 stent, and the radial force is maintained, totally maintained, or even enhanced, which is very good for the stents. In this example, a 3.520 Synergy MEGATRON was implanted in the distal lead main. After post-dilatation, you still see some malposition in the most proximal lead main because the lead main is very large. But finally, we could post-dilate this stent to 5.3 millimeters with good apposition, and the radial strength is totally preserved. We have to optimize the procedure. And with the provisional stenting technique, how we optimize. We have several cutoffs or thresholds for the lumen based on ASEAN population or Caucasian population from the EXIT trial, but we use our protocol that has been tested and published in neurointervention recently and provide an advantage in terms of prognostic evolution compared to angiography and to the conventional use of IVUS. And this is the protocol which for ostial and mid shaft, we use the criteria of an expansion of the stent more than 90% of the distal reference lumen in the lead main. We also consider for funnel shape lead main downgrade of the expansion to 80% as enough. And for this, I'm going to show an example of this. This is a lead main disease diffuse in a long lead main. The operator didn't evaluate the lead main with IVUS baseline, just implanting the stent 3.523. The result was apparently good, but with IVUS was evident that the ostium was not covered. And you have a residual stenosis in the lead main ostium with 5.2 square millimeters lumen. Then a new stent should have to be implanted. In this case, IVUS was able to detect a problem, but maybe a baseline study would have prevented this. For distal provisional, we have also this criteria of the 90% expansion, 80% in cases of tapered lead main, which is not uncommon. An example of this is a lead main disease, not very severe angiographically, but with IVUS we see this lumen, which is significant, 5.5 for the lead main, which is in the borderline, and around 4 for LAD and lead main. FFR was clearly significant in LAD, not in CERT, and here was borderline. And based on the lumen of LAD, we implanted a 3.5 24 millimeters stent with a pot 4.5, good result in the lead main stent, but circumflex was compromised. The lumen was decreased even after kissing, and because we have the wire in the table, the pressure wire, the FFR assessment was negative, was positive, was 0.72. Then this is an example of bailout to a stent technique after a provisional that it was not really successful. And in this case, we use a tap technique because the angulation was appropriate, and we implanted a 316 in CERC, casing balloon, repot, and finally, this good result with lumen of 11, 7, and 6, respectively, in lead main, LAD, and CERC, which is appropriate. If we go to the next, is the two-stent technique, how to optimize here. Again, the same similar criteria, but in this case for both, we have this complex distal lead main with involvement of of circumflex particularly, but also in LAD. And after two stents in culotte, we can see how we are optimizing. For example, the lumen in the mid-distal lead main was initially 76%, was expanded, and we were able to reach a 97% expansion with proper pot, kissing, and repot. The expansion in the LAD and CERC was also optimal, over 90% in both cases. Then I think you should do IVUS in the procedure just to get in the possible, if it's possible, to get the results that you are expected, and then to warrant the best outcome. Then, as conclusions, we can say that IVUS imaging guidance for lead main PCI is very helpful to plan the strategy, to the preparation of the plaque, the stent sizing, and optimizing the results. This is not really just a static thing, because we have demonstrated that IVUS guidance or lead main stenting provides a prognostic benefit with respect to the use of angiography alone, particularly if you use a protocol with predefined optimization criteria. Thank you.
Thank you very much, Jose Maria. I think it was a very nice presentation. We have time to discuss about IVUS or intracorneal imaging for left main. I think it's very important, especially for people who are still in the learning phase with left main. We have learned in Excel, as you know, that there was 7% of cases where there was a longitudinal distortion of the stent at the ostium mainly. And we learned that it was associated with a double risk of MACE at 4 years follow-up. So I think it's also a very important technical issue to avoid this kind of problem, and it's not so easy. Of course, it depends also on the stent radial strength and the radial longitudinal strength. So what is your opinion about that?
Yeah, in the protocol I showed, but for the sake of time, I didn't explain the whole picture. But the people can see the slides. We see the assessment of the deformation, proximal deformation. And in this point, the report is very important, because with the report, you are going to fix most of the deformations, or all of them. But anyway, after the report, a final IVUS run with the catheter disengaged from the lead main is very important, because if you are going to have any deformation of the stent, it's going to be in the most aorto-ostial segment. Then you have to do the final IVUS examination with the catheter disengaged. And then when you see that everything is okay, you just remove the catheter, because it's the catheter, the one that if you try to engage again to do a new angiography, you maybe are crashing the stent.
So in your opinion, the final report, proximal report at the osteum is very important.
Exactly, very important, very important.
Okay.
I think there's a few fundamentals that, you know, IVUS before is useful for. There tends to be a perception that do it afterwards, check everything, it's okay. But actually, where we are now with the options for calcium modification, I think understanding calcified arcs and seeing if there's concentric calcification, and taking a predilation balloon that's really going to inform you in a very large vessel if that vessel will expand or not. So it's no use dilating an LAD or a left main with a 2.0 balloon. I think you maybe need to be at 3.5 or 4 or something that's appropriate, and understanding what that is very important in contemporary practice. I think the other thing is the pot aspect of the technique. It's crucial that once you put a stent from a daughter vessel into the large left main, that pot is undertaken at every step. And the IVUS gives you a roadmap in terms of what size that balloon should be and how you should go about the procedure. And it probably actually saves you time, contrast, and radiation. And I think it makes the job better.
Yeah, definitely that there are many advantages, not only in the prognostic, but also in the procedural and logistics, no? Less contrast, less time, because sometimes you are doing a lot of projections with angiography to check if the result is good. Just do an IVUS examination and it's okay. You're going to be very sure, and you're going to get assurance about the result. And also this, I didn't mention, but the stent edges in the LAD and CERC, you have to check, because sometimes a dissection there or an hematoma there are going to ruin all the nice job that you made in the lead main. Then the stent edges, both proximal for the deformation, distal for any kind of dissection or hematoma, the expansion and deposition are the 4 important key points to consider, to take into account.
Jose Maria, in the left main, in your opinion, what is the position for, or your position for OCT or FDI?
For OCT, we have been doing a registry with comparing OCT and IVUS, will be published soon. And we have seen that OCT can be used, but there are some problems. For example, in ostial and mid-shaft is not really good, because you have a lot of blood contamination. For distal, it's useful if you don't have a very large lumen of the lead main, because then it's very difficult to clear out all the blood. Also, you have the problem that OCT, the catheter is much more floppy, and then to cross, for example, through the stent in case of jailing is going to be difficult. But anyway, some people is using OCT for distal and main is an alternative, but I prefer IVUS because I can see the whole vessel, the plaque burden, the full vessel size in order to do the pot properly and to stent sizing properly. And I prefer definitely IVUS as my preference, and it has more advantages than OCT in the lead main setting.
And what about the struts, selection of strut? Do you think that with IVUS you can assess that correctly, or do we need OCT?
I mean, the IVUS shows exactly the same information. You just need to know how to interpret it. The easiest way is actually to track the wire on the long view. And as you're pulling the long view back, you can see if you've crossed a distal cell or a mid cell or a proximal cell. Does it actually make a huge difference? I mean, there are theoretical mechanical differences in outcome. The October study will hopefully help inform us if it is very important or not. Personally, I think the operator doing the case might be more relevant. And I think these sort of strategy trials of imaging versus not, the difficulty is that the people who are doing them typically know what they're meant to be doing. So it's hard to show a difference. But we'll see how October pans out.
Other problem with OCT is the contrast. You are going to have, if you need 3-4 runs, you are going to spend maybe 30 cc's more or contrast, something like that. And then I think so. There are several things to consider.
Okay, Thank you very much. I think we can move now to what you have done, Simon.
Okay, so let's review how the case proceeded. So the first thing was, as Thierry had pointed out, the patient was very keen for PCI rather than bypass surgery. He was fully informed about the potential nuances between the two treatments, but was happy to proceed. So that's what we did. Just reviewing the angiographic images, we've got a hazy severe lesion in the main stem, which looks acute angiographically. Significant atheroma in the LAD and a critical lesion in the mid-vessel, and then a couple of severe lesions in the circumflex as well. The first thing we did was wire both vessels to secure them, and then a balloon inflation with an adequately sized balloon, so 3 millimeters, to ensure that the left main is dilatable, but also the mid-circumflex as well. And once that's been established, we've got better blood flow and a more stable situation. And we're able then to undertake IVUS of both limbs. So the IVUS of the circumflex is interesting. It's a big vessel, 3.5 millimeters distally. There's a heavy plaque burden with severe disease proximally, but we've got a healthy landing zone for a stent distally. The left main itself is somewhere between 4.5 and 5.0. Although if you are sizing to EEM, you do need to be a little bit careful because you will get positive remodeling of diseased vessels, and you don't want to be too aggressive with the sizing. The other interesting thing in the right panel that you see in the left main stem is ulcerated plaque with a lipid-rich plaque there that's being the cause of the acute deterioration. In the LAD, in the mid-vessel, we didn't put the probe right to the bottom of the LAD because the patient got a lot of ischemia. So the mid-vessel in the LAD is 3.0, as you might expect. Approximately it's between 3.5 and 4, again, as you would expect in a healthy male. So what has IVUS given us at this stage? It's basically given us a full roadmap for our PCI. We know that we can reconstruct the circumflex with 3.5 millimeter stents. We know that the circumflex and LAD are actually well matched in diameter without any hostile angulation issues. So in my mind, when that's the case, I think culotte as a technique is mechanically very predictable and leads to excellent outcomes. We know that our left main pot balloon should be 4.5, and that's a crucial step. Every time the stent goes from a daughter vessel back to the main stem, there must be a pot. So we can pick that balloon sensibly as well. And then the distal LAD, where we've seen the IVUS land is 3 millimeters, and approximately ostally it's 3.5 to 4. So we know what stent sizes we require in that region as well. So the initial stents were deployed from the distal portion of the circumflex, covering all of the plaque, back to the proximal left main stem. You'll see at the top end there that there's relative recoil in the left main segment, and that's despite having undertaken a pot inflation with a 4.5 millimeter balloon. So the circumflex stents have been deployed and have been optimized. The left main has been dilated with a large pot balloon, but because of the burden of atheroma there, mechanically we don't quite have what we're striving for at this point in this procedure. The next step is to rewire the LAD. You try to pick a cell as close to the carina as possible, so that the technical step is to drop the wire in the circ, pull it back and try and wire the LAD as close to the carina as you can manage. Sometimes it's tricky to get a secondary equipment through there, and in this case that proved to be difficult. So we tried initially with a standard balloon, then we tried with an anchor balloon in the circumflex, which was unsuccessful. Then we tried a very small balloon with an anchor balloon in the circumflex, and again it didn't go. So the solution here has been to use a microcatheter, which is a Mamba Flex in this occasion, which is delivered through the stent across into the LAD, down distally, and then we're able to use an extra support wire to also help out with the delivery of subsequent equipment. And that can be an issue with the culotte technique. Sometimes it gets a little bit tricky to get into the other vessel. Ultimately, we did have to use a guide catheter extension to get ourselves into the LAD to deliver long stents. And what I'm demonstrating here is just the inchworm technique, where a balloon is inflated across into the LAD, and as that deflates, the guidezilla hair is advanced into the LAD to facilitate stent delivery. Then we deploy a 2.548 synergy. It goes a bit more distally because there was plaque further down, with post-dilation to 3 millimeters in the mid-vessel, 3.5 millimeters at the top of that stent. Our next thought process is how do we optimize the left main stem? And as we saw with the relative recoil, I think taking a stent like a MEGATRON in this circumstance is a good choice, primarily because it's resistant to axial compression and longitudinal deformation, but actually more importantly for the radial strength, which is going to give us excellent expansion in the left main. So we don't need to make this 6-0 because we've seen by the IVUS that it's not a huge left main, but we certainly want the radial strength of the MEGATRON to ensure that we get a good mechanical result. So this is a 3.532 MEGATRON, just overlapping with the mid-LED stent and coming back to the left main ostium, and that's deployed nicely. Again, a crucial step is pot. So as soon as the MEGATRON is deployed, a 4.5mm balloon is put in and inflated to make sure that the stent is opposed and that we're not going to risk any longitudinal deformation. The next step after that then is kissing inflation, and these are two 3.5mm NC balloons, which are both well expanded. Now we get into the IVUS algorithm, and we want to make sure that we check all the things that Jose Maria has mentioned. So number one, the distal edge, that we've got no dissection. Our distal reference is just over 4.8mm squared, and whilst the LED stent diameters did get to more than 90% of that number, I felt that there was a segment of relative underexpansion distally. So IVUS is not just about taking pictures, it's about acting on what you see. So we did go back to that mid to distal LED and dilate it to very high pressure with an NC balloon to optimize things. In the left circumflex, the distal edge has no dissection. Our reference segment is 6.2mm squared, and you can see that the minimal stent area exceeds that number, so we're certainly over 90%. So we're happy with the stent expansion throughout the left circumflex distally. And then when we look at the proximal vessels, we're striving to achieve something in order of 8 to 10mm squared if at all feasible in these large vessels. And we've hit 9.7 in the LED and 9.5 in the left circumflex. So good stent expansion and good areas in both vessels. I'll just let this run through. It's about 40 seconds. And this is just an IVUS pullback from the left circumflex. You see a small branch there down towards 5 o'clock, coming back up towards the LED circumflex bifurcation there, with no struts lying across the bifurcation. And in the left main, you see that this MEGATRON is providing excellent radial strength. It's circularly expanded. And the other key point that we talked about earlier is that there's no longitudinal deformation. So you want to make sure that the ostium is covered, which it is here. There's not too much stent in the aorta, and there's no evidence of that involuted double layer of stent at the top end, which would be consistent with LSD. So that's basically a good checkbox in terms of making sure the ostium is appropriately covered and there's no deformation there. In terms of our area assessment, we're almost at 12mm squared at the distal left main, and we're at 14mm squared at the ostial left main. So very nice results in terms of the areas in those two regions. So again, just using Jose Maria's stepwise checklist, I think we have ticked off each one of all of those aspects to make sure that we've done a good job for this patient. Our final angiogram, I think, looks significantly improved. And here's a cranial view as well, demonstrating basically excellent flow into both the vessels. All the branches are preserved. There's a little bit of minor nipping in one diagonal, but overall, I think we've achieved a very good result for the patient. So for this case, I think the MEGATRON did lead to a better mechanical outcome with good radial strength in the left main stem. I think the Q-lock technique is something that is quite durable, and we've seen the results from Celtic that once you get a good acute result, your chances of having later problems are very low. I think the point that IVUS actually saves time. It gives you a roadmap for your procedure, for your equipment, what to do, and certainly saves radiation for the patient and for the staff. And I think the IVUS-based optimization is all about the long term. So it's not about getting a patient off the table without a complication. It's about how they're going to do in the very long term and to make sure that we've got the most durable result that we can for the patient.
Thank you very much, Simon, for this excellent case. I think it was perfectly done with a very good result at the end. I'm sure that the outcome of this patient will be good for long term. What will be your strategy for DAPT? 6 months, 1 year, more than 1 year?
I think officially he's plaque rupture with an unstable presentation. Whilst there was no troponin, it truly is an acute coronary syndrome. So 12 months, just following normal guidelines. But I mean, I would have no concerns if it was an elderly, frail patient with high bleeding risk to shorten that to 1 month if I had to. So for me, the patient kind of dictates if you need to shorten or not. But I don't think the fact you've stented a left main and left it like that is any indication for prolonging dual antiplatelet therapy.
Did you work with 6 French or 7 French guide?
That was 6 French transradial, and I deliberately chose a slightly shorter guide because I didn't want to have catheter damping and to fight with sort of ischemia during the case. So that was a Voda left 3.0, 6 French from the right radial.
Okay. I think it's a very important point because up to 3.5 for both vessels, you can go through 6 French. I noticed also that you selected an extra backup catheter or equivalent to extra backup.
Yeah.
Many people like to use GL. I think it's a mistake to use GL because you lose support, especially for going into the circ.
Yeah.
So what is your opinion?
I agree wholeheartedly. I would I'd never use a Judkins guide anymore for left coronary intervention.
Yeah.
And it's that if you've got angulation and calcium into the circumflex, it can be very challenging. And I think a Judkins guide under those circumstances is actually a hindrance and a potential source of a problem in the case. And I would encourage people not to do that.
Before commenting some details, it's very important. The case is outstanding, Simon. It's perfectly done. And you use IVUS in a very wise and proper way. And in your conclusions slide, you say that it's likely to promote a durable outcome. I think we have registries suggesting, we have a registry as well in Spain, that IVUS in left main stenting improves a prognosis with respect to angio, but ultimately the definitive answer would be provided by a trial, which is going to start very soon, optimal trial in 800 patients, randomized 1-to-1 angio and IVUS, and in 3 countries in Europe, over 25 sites. And in this trial, we will give the definite answer to this, no? Because the results are very good with IVUS, but we have to demonstrate that this really improves outcomes, hard outcomes for the patient. And said this, my only question is, of course, you use IVUS properly because you size the stent, you size the pot, you finally provide the lumen in the stents, which is very nice. But the most important trouble here was the recrossing to LED. And what is your strategy when you do culotte, to start with CERC or to start with LED first? What vessel do you stent first and what do you stent second?
Assuming that they're all equally diseased, basically the stent that goes in first, in my mind, is the one that's most difficult to deliver.
Yeah.
Recrossing to deliver it can be more difficult again. So if there's a retroflex, circumflex, for example, I would treat that first. So whatever's got the most hostile angle into it, and it's usually the circumflex with left main bifurcation. That's my thought process. I don't know if anybody would do anything different.
I think it's a very good point, and we have data from our Japanese colleagues who have done bench testing, starting first with a CERC or starting first with LED when doing culotte stenting, and they found that starting first with a CERC is better in terms of final result in the architectures of both stents. So I think and this is what we are doing in our lab, and I think it's a very good approach. Maybe you can.
Caveat, sorry, Thierry,
Yeah.
which is if you've aggressively pre-dilated both, that you may see a dissection somewhere, and if one of the vessels may be compromised, you may want to stent that one first.
Yeah,
that's the only
of course, yeah. One thing that you can explain, Simon, is the tips and tricks for problems when going through the struts in the LED, as you had some technical problems. And there is many steps that you can use. You have described many of them because you went in the escalation of techniques in order to be able to cross. I think there is some alternatives which are doing another pot or checking which strut you went through, because sometimes you have difficulty because you are too much distal or sometimes you are too much proximal.
Yeah.
So what did you check with IVUS?
I actually did, but because the presentation time is less, I didn't add the full run. But on the IVUS, you could see, first of all, that the second wire was in the lumen, so it had not gone outside the stent. And if your pop balloon is inadequate, that remains a risk, particularly if the guide's coming back and forwards. So you do need to consider, if equipment won't advance, that there may be something different, and imaging can be very informative. Actually, we had an excellent distal cell cross, and we had a wire in the lumen. So the IVUS told us everything was in the right position. There was just a bit of an angle at the LED ostium before it was resolved. So we had a good pot. Normally with the modern stents, if you put an anchor balloon in the vessel that's already stented and inflated, it will help you get a second balloon through. It's rare that you need to go beyond that step, I think, in modern practice. If you're quite distal in the vasculature, using a guide catheter extension may solve the problem. But upgrading to a stiffer bodied wire will stop it sort of prolapsing away from the carina. So as the balloon comes along, and if you imagine that, see if we can get this on camera, there we go, that the wire prolapses down towards the circumflex rather than going into the LAD. So the stiffer wires, just standard workhorse extra support wires, will often resolve that problem as well. And the combination of those things is usually enough. But you can use the microcatheters that we use for CTO to recross. They will get through, whereas balloons may not. And once you've done that, often actually you can put a balloon through anyway as well.
Yeah. It's a very important point to check the rewiring with imaging, because sometimes you just are doing, because you didn't do IVUS, the stent is not opposed and you don't know it in the lead main, the wire is going out, then in, goes to LED, and you try to push a balloon, and you are the distortion, creating distortion in the stent, and sometimes even you can cross to LED and you crash the stent in lead main. Then for the rewiring, particularly when you see any resistance of the balloon, you should do imaging. You should do IVUS to check the position of the wire, and then the position is okay. Then you can push with the balloon or change micro or other techniques. But it's a very important point.
Okay, just a last question about sizing. I think it's not so simple to size the left main, even with the IVUS, because you may have negative remodeling or positive remodeling. So how do you do it? I saw that at the end you have a 3.5 circ, a 3.5 proximal LED. So if you make the calculation according to the Finet's law, it would be 4.7. This is what you have done at the end. You finalize the result with a 4.5 balloon at high pressure, so very close to 4.7.
Yeah.
So what do you think?
Well,
how to size properly the vessel when you use IVUS or FDI or OCT?
I think if you've got a healthy segment, it's very easy. We have to remember that most of the IVUS trials and things that have informed our practice are based on lumen dimensions, not EEM. So in a diseased vessel, you do need to be a little bit careful about going out to the EEM, because often you get positive remodeling with plaque, and it can encourage you to go way too big. So in this case, I think taking a 4.5 balloon, where we saw the EEM measurement 4.7 in the left main, which was diseased throughout, was safe. It was unlikely to promote a perforation. So if you're using IVUS to size and that you've got a perfectly healthy segment for reference, that is easy decision.
Of course.
And if you've got disease throughout, I think you just need to be a little bit pragmatic, that you don't want to be very aggressive to EEM, or certainly not beyond EEM, that's for sure.
Yeah, absolutely, because the oversizing, you have the distal problems in the edge of dissections and hematomas, and also it can be even rupture in cases of very elderly patients, particularly women. If you are very aggressive, you can have catastrophic. It's very appropriate comment.
Okay, so thank you very much. I think we had a very nice case, a very nice discussion. So it's time to wrap up this session. So I hope that you had a good session. I think we have learned a lot from Simon and Jose Maria. So it's time to wrap up. You have seen this case, which is a complex case with a lot of disease in the left main, also disease in LAD and circ. And of course, preparation of the procedure is very important. Having a good strategy is very important. You have seen that at the end, after using a culotte technique, they had a perfect result in both branches and the left main. Of course, you have alternative to a culotte, could be a T-stenting or tap, or some people will like to use a decay crush technique. This is a paper that will be published very soon in CCVI by Francesco Buzotta. It's a summary of techniques that are recommended from the European Bifurcation Club. And you can see that when you use a culotte, you should do at least 2 pots after stenting the first branch and also after stenting the other branch in order to be able to go through a distal strut. And at the end, doing a final pot up to the ostium is also very important in order to stent fully opposed and correct sometimes deformation that you may have due to longitudinal compression. Now we have seen a lot of discussion about IVUS, and I think it's very nice when you use 2 stents to have an optimal left main expansion, to have optimal LED and LCX stent expansion, as it was mentioned by Jose Maria, and of course also avoid longitudinal compression and optimal lesion scaffolding. Now we have seen that they have used a MEGATRON stent, which I think is very interesting because the design is specially made for treating left main or ostial right coronary artery or very big vessel, because there is a high radial strength and also a better expansion capacity due to the special design of the stents. There is 4 connectors at the proximal part of the stent, which give you a very good axial strength, as you may see here. So when you compress, you have a very good strength as compared to the synergy. You can see it's completely different. So I think it's very important for this kind of left main to have an optimal stent, which is specially designed for treating this kind of lesion. So I thank you very much for your presence to this course PCR, and I wish you a good evening.